Hi everyone, welcome back to Izzy Medicine. This is part 2 of our Acute Coronary Syndrome series. In part 1, we broke down how a vulnerable plaque ruptures, how clot forms, and how blood flow to the heart muscle suddenly drops. We met our 57-year-old patient, and he's still in front of us. He's pale, sweaty, clutching his chest. So what do we do for him? Well, the very first diagnostic move is the 12-lead EKG, and it has to be done right away, hopefully within 10 minutes of arrival. This is not just a guideline, it's a must because every minute that we wait is more myocardium lost. So once we get this EKG, along with troponins, hopefully, we have to work through our ACS spectrum. So let's start with the most dramatic presentation, the STEMI, the ST elevation MI. So if our patient is actually having a STEMI, that means that his artery is completely blocked. There's zero blood flow. And when we talked about the pathophysiology in part 1, we learned that this creates a full thickness infarction. The damage goes all the way through the heart muscle wall. That's exactly why the EKG changes are going to be so obvious. So what do we see on EKG with a STEMI? We see 1 or more millimeters of ST elevation and at least 2 contiguous leads. The exception here is in V2 and V3, which are closer to the heart and have a slight ST elevation to begin with. We need 1.5 to 2 millimeters, depending on the patient's sex and age. What does contiguous actually mean? It means that it's looking at the same wall. For example, leads V2 through V4 look at the anterior wall, so they're contiguous. So we would need to see an ST elevations more than 1 millimeter in V2 and V3 or V3 and V4 or all V2, V3, V4. Similarly, leads 1 in AVL, for example, look at the high lateral wall and that makes them contiguous. So we would need to see lead 1 and AVL both with ST elevations. We never call a STEMI on one single lead. We basically need 2 neighbors agreeing on the situation. Now there's also something interesting about timing of symptoms and onset. Sometimes we'll actually see changes before the ST elevation appears. These are called hyperacute T waves. They're tall, broad, and symmetric T waves that show up because the ischemic cells are leaking potassium and they alter repolarization. So if we catch these early, we're actually seeing the very beginning of a STEMI in progress. Another thing that we look for when we look at the EKG are reciprocal changes, and this is something that really strengthens our diagnosis. When we have a full thickness injury, the electrical current flows towards the damaged area. Leads looking at the injury see ST elevations, while leads on the opposite side see ST depressions. So for example, in an inferior STEMI with ST elevations in 2, 3, and AVF, we'll often see reciprocal ST depressions in 1 and AVL. This is our clinical ace in the hole, so to say. When you're wondering, is this an ST elevation or just benign early repolarization, we'll look for reciprocity. Benign causes, pericarditis, don't give us that mirror pattern. So if we see it, we can confidently call it a STEMI. Now, we drew troponins, hopefully, when our patient came in, along with doing the EKG, and we're going to look at them now. So here's the thing. The troponins will rise very high eventually, but patients with a STEMI usually get to the ER fast because these symptoms are so severe. They arrive with crushing chest pain within an hour or 2, and at that point the troponins often haven't peaked yet. With conventional assays, it takes 2 to 6 hours for troponins to rise after symptom onset. With high sensitivity troponins, you might see elevation within 1 to 2 hours, but early on they can still be normal. That's why we repeat troponins, to catch the rise. But here's the key. In a STEMI, the EKG makes the diagnosis, not the troponins, because you can't wait around for serial troponins when the EKG is screaming at you with ST elevations. Every minute you wait is more muscle lost. Now, let's talk about the hidden infarct. This is one type of a STEMI that's notorious for being missed, and I guarantee you'll see this on the boards, the posterior STEMI. Here's the problem. Our standard 12-lead EKG has a blind spot. It doesn't actually look at the back wall of the left ventricle. So when the posterior wall is infarcting, you won't see the classic ST elevation you're expecting. Instead, you'll see something that looks completely wrong at first glance. You'll see horizontal ST depressions in V1 through V3. At first glance, it looks like anterior ischemia, but really it's the flipped view of posterior ST elevation. So if you're suspicious, which if somebody's having chest pain plus those unexplained anterior depressions, you should be, you need to place posterior leads V7, V8, and V9. And they go along the left posterior axillary line and left scapular area, basically in the back of the patient. And it's essentially wrapping around to look at the back of the heart. If it's a posterior STEMI, you'll uncover true ST elevations there. And troponins here behave like any other STEMI. They rise because this is still a full thickness infarct. The danger is missing it if you don't think to add those extra leads. Now let's shift gears to an NSTEMI. What does an NSTEMI mean? It means that the artery is partially occluded. Some blood is still getting through, but not enough. The damage is not full thickness. It is confined to the inner layer, the subendocardium. Why does the subendocardium get damaged first? Boards love this concept. The subendocardium is the most vulnerable because it's furthest away from coronary supply, it has the highest oxygen demand, and it is squeezed the most during systole. That makes it the first to die when the flow drops. So when you're looking at the EKG in an NSTEMI, you need to think differently than you did with a STEMI. Because this infarct is only partial thickness, you're not going to see those dramatic ST elevations. What are we going to see in a non-ST elevation MI? We see ST depressions that are flat or downsloping, and we can see T-wave inversions, especially in V2 through V4. Now, let's talk about troponins in an NSTEMI. Troponins are elevated because the subendocardium cells are dying. Here's the key point. Patients with an NSTEMI often wait longer to seek care because their pain may be less severe, or they may only have shortness of breath, nausea, or fatigue. That delay gives time for myocardial damage to build up. And so by the time they reach the emergency department versus our STEMI patient, troponins are often already positive, and that's how the diagnosis is made. Then we move down the ladder to our unstable angina. An unstable angina is kind of like the warning shot, the step before an NSTEMI. The artery here is narrowed by a clot, but flow is just enough to prevent necrosis. This is ischemia without cell death. On the EKG, what we might see is transient ST depressions or T-wave inversions during an episode of pain. But the tracing often normalizes when the pain resolves. Sometimes it looks completely normal. That's because the ischemia is reversible. The muscle is starved, but it's not dying. And here's what makes unstable angina different: the troponins. The troponins stay completely normal, even with those super-sensitive assays. This is the key dividing line that boards absolutely love to test. Think of it this way. NSTEMI means you have ischemia plus cell death, so troponins go up. Unstable angina is just ischemia without cell death. The muscle is crying for help, but it's not dying yet, so troponins stay normal. So now that we understand the different types of ACS, let's talk about localization and why it's important. Here's how to read the territories. V1 through V4 is our anterior wall. It's supplied by the left anterior descending artery. 2, 3, and AVF is our inferior wall, and it's supplied by the right coronary artery. 1, AVL, V5, and V6 are our lateral wall, and it's supplied by the left circumflex artery. And V7, V8, V9, our posterior wall, is supplied by the posterior descending artery. The posterior descending artery usually comes from the right coronary artery, but sometimes from the left circumflex, depending on whether you have right or left dominance. Why does this matter? Well, each territory carries different risks. For example, if we see that we have an anterior MI from the left anterior descending, this is our widowmaker. You lose the most muscle mass because the left anterior supplies the largest territory. These patients in particular are at high risk for cardiogenic shock and pump failure, so we gotta monitor for that. If we have an inferior MI from the right coronary artery, the danger here is that the right coronary often supplies the right ventricle too. So an inferior MI can extend to involve the right ventricle. Why does this matter? The right ventricle needs adequate filling pressure, so preload, to pump blood forward. If it's infarcted, it can't squeeze properly, so it becomes completely dependent on having enough volume coming in. So giving nitrates and diuretics to someone with right ventricular involvement, we can drop their preload and their blood pressure will crash. So how do we check for right ventricular involvement? Well, we place a right-sided lead called a V4R. This is just like V4, but on the right side of the chest instead of the left. So if you see ST elevations in V4R, that confirms that the right ventricle is infarcted, and these patients need fluids, not nitrates. And then, our lateral MI from the left circumflex artery can be sneaky. The EKG changes are sometimes very subtle, so we need to really scrutinize the high lateral leads, 1 in AVL, or we can possibly miss it. And of course, our posterior MI, we can miss these completely unless we remember to add leads V7, V8, and V9. Alright guys, that was part 2, the detective work. We've covered how to use EKGs and troponins to diagnose a STEMI and NSTEMI and unstable angina. Remember, STEMI is EKG driven, NSTEMI is troponin driven, with patients presenting later, and unstable angina has normal troponins. In part 3, we're going to tackle management, reperfusion, medications, and pitfalls to avoid. Thank you for watching Izzy Medicine. If this helped, hit like, subscribe, and see you in the finale. Bye!